The emergency room at County Medical Center operates on a rhythm that most people never witness. It is a rhythm built on crisis and protocol, on split-second decisions, and the accumulated weight of medical knowledge applied in real time to bodies that are failing in front of you. The nurses know this rhythm. They move to it the way dancers move to music they have internalized so completely they no longer hear it consciously. They know where to be before they are told where to be. They know what will be needed before the doctor orders it. They have made peace with the fact that some people will die no matter what they do, that the system will process those deaths and move on, and that they must move on with it because there are other bodies, other crises, other opportunities to intervene before it is too late. This is the agreement they make when they enter the profession. They learn to compartmentalize. They learn to function within loss. They learn to separate the person from the medical emergency because separating those two things is the only way to keep working without breaking. But there are moments when the rhythm breaks. Moments when something arrives that does not fit into the protocol. Something that disrupts the careful dance between competence and emotional survival. For Elena Vasquez, one of those moments arrived at 2:17 a.m. on a Wednesday in late September, when an ambulance pulled into the bay carrying a critically injured Special Forces operator with trauma injuries that suggested his operational security had been compromised in ways that would require notification to several government agencies. Elena had been at County Medical for 11 years. She was the kind of nurse that new staff did not always notice on the first pass. She was quiet in the way that competent people are sometimes quiet, not shy, but economical. She spoke when words were necessary. She moved with purpose, but not haste. She had dark hair that she wore pinned back in a style that had not changed in 5 years. She wore her scrubs in the exact shade of blue that blended into the background. She had a reputation as reliable, which in hospital politics meant she was someone you could trust to do the work without complaining, without drawing attention, without creating problems. But she also had a reputation for something else, a reputation that most of the daytime staff did not fully understand. She was someone who had been somewhere else before this. You could see it in the way she moved when a critical patient arrived. You could see it in the understanding in her eyes when she looked at certain injuries. You could see it in the way her hands never shook, no matter how chaotic the situation became. The newer nurses sometimes asked her how she stayed so calm. She never gave them an answer that made sense. She would simply say, "Experience," and move on to the next task. What she did not tell them was what kind of experience. What she did not tell them was that she had been a combat medic with the rank of sergeant, that she had spent 8 years in a ranger unit stationed at Fort Lewis, that she had been part of deployments to the Korangal Valley and Fallujah during the height of combat operations. What she did not tell them was that she had sat in helicopters flying over hostile territory, knowing that people were going to die, and that sometimes the only thing she could do was control the manner of their dying. That she had made split-second decisions about triage and treatment in environments where every second mattered. She did not tell them that she had been good at that job. She did not tell them that she had been called Ghost because of the way she could appear in the middle of chaos and make order from it. That her presence could calm a panicked soldier. That her hands could save lives through actions that most civilians would find incomprehensible. She did not tell them that she had held soldiers' hands while they died from wounds that no amount of medical knowledge could fix. That she had been the presence that meant someone did not have to face their ending alone. She did not tell them about the weight of accumulated loss, about holding too many hands, about understanding how fragile human life was and how temporary everything could become. She did not tell them that she had left because she had to, because staying meant drowning in accumulated trauma and loss, and she had decided that the world might need her to drown more slowly in a different place. a place where she could still help people, but where the cost would not be quite so absolute. Elena was on the night shift when James Walsh arrived. James Walsh was a call sign, though nobody called him that at the hospital because his medical record contained his real first and last name. And the military operated by specific classifications about what could be known and what could not be known. And the distinction mattered. He was 34 years old and built like someone who had spent his entire life training his body to survive, in conditions where survival was not guaranteed. He had tactical scars, the kind of scars you get from repetitive high-stress situations in hostile terrain. He had been brought to the hospital by a rapid response team that had extracted him from a location that nobody was permitted to know the name of. From an operational context that was classified, from circumstances that the hospital intake nurse was instructed not to document beyond the immediate medical necessity. The intake form listed his injuries in clinical language. Severe blunt force trauma to the torso resulting from blast fragmentation, multiple puncture wounds consistent with shrapnel penetration, a tension pneumothorax on the left side that had partially collapsed his lung, internal bleeding that had been slowed but not stopped by the field medics who had extracted him using improvised pressure dressings. The prognosis was uncertain. The goal was to stabilize him enough for transport to Walter Reed, where they had the surgical resources and specialized trauma staff to manage complex combat injuries. The timeline was critical. Every hour that passed was an hour his body was fighting against odds that grew worse with each passing moment. The trauma surgeon, Dr. Marcus Reynolds, who had graduated from Yale and mentioned this fact in nearly every conversation, who wore shoes that cost more than most people's car payments, who had a tendency to treat the nursing staff with the kind of dismissal you reserve for support staff you believe are beneath your intellectual level, looked at James Walsh's chart and made an immediate assessment. The patient was conscious, which was both good and bad. Good, because it meant there was neurological function and he might be cooperative. Bad, because a conscious patient in extreme pain tends to fight against the medical interventions that might save his life. Dr. Reynolds had dealt with this before. He had protocols for managing agitated patients. He had medications, propofol, etomidate, midazolam, that could override patient resistance through pharmacological means. He had an understanding of how to assert medical authority over patient autonomy for what he believed were legitimate medical reasons. What he did not have was an understanding of the specific resistance he was about to encounter. The kind of resistance that came from training designed specifically to resist the loss of control. James Walsh was awake when they brought him into the trauma bay. His eyes were focused and clear despite the pain that was clearly coursing through his body. The monitors showed elevated heart rate, reaching 115 beats per minute. Elevated blood pressure at 165/98. Elevated respiratory rate at 28 breaths per minute. The physical signs of extreme stress and hypovolemia. His oxygen saturation was holding at 92% despite the compromised lung, which meant he was maintaining oxygenation through pure will and training. His hands were clenched so tightly that the IV lines they were trying to place kept getting disrupted by involuntary muscle contractions that were partly pain response and partly protective reflex. The nurses were working with professional efficiency, placing a 20-gauge peripheral line in his right antecubital fossa, preparing to insert a larger bore line, 16-gauge or 14-gauge angiocath in the left antecubital area, for rapid fluid resuscitation that could pump liters of normal saline through his compromised system to maintain blood pressure and tissue perfusion. They were also preparing the equipment for central line placement, either subclavian or femoral access, which would allow multiple medications to be administered simultaneously, which would allow the surgeons to monitor his central venous pressure. But there was already a sense of frustration building. He was not cooperating. He was not following the standard protocols for a trauma patient. He was instead watching every person who came near him with an intensity that suggested he was evaluating something beyond the immediate medical situation, something that looked like threat assessment, as if he was running military operational calculations about who could be trusted and who represented a threat to his safety. "We need to get 2 more large-bore IVs in place," Dr. Reynolds said, not speaking to anyone in particular, but knowing that his words would be acted upon. He was already moving toward the patient, already beginning to examine the injuries with the kind of detached analysis that comes from years of training. Elena was moving too, placing equipment, preparing the room, doing the 1,000 small things that make trauma surgery possible. But she noticed something that Dr. Reynolds did not notice, something that most trauma surgeons would not notice because they were trained to focus on the body and not the person inside it. She noticed that James Walsh's eyes were tracking every person in the room, that he was monitoring the location of the exits, that his breathing patterns followed military cadence, controlled, measured, the breathing patterns of someone trained in stress response and pain management through physical discipline. She recognized these signs because she had trained with them, because she had once been trained to notice who was trustworthy and who was not, who could be depended on, and who might become a liability. "What's your unit?" Elena asked quietly, moving close enough to monitor his shoulder where they were trying to place the second IV. The patient's eyes locked onto hers for exactly 1 second. That was all it took. 1 second of contact, and she understood what he was doing. He was not panicking. He was not confused. He was assessing the room for threats. He was in crisis response mode, a military mode, which meant his training was overriding his judgment, which meant he was potentially more dangerous to himself than his injuries. 75th, he said. The 2 words coming out in the clipped, precise way that soldiers speak when they are in pain and fighting not to show it. Elena understood immediately. 75th Ranger Regiment. Her unit. The same unit she had left 8 years ago, the same unit where she had been called Ghost. Not because she was quiet, but because of the way she moved through operations, the way she could appear where she was needed without anyone quite realizing she had gotten there. The same unit where she had sat with people who were dying and made the choice to either let them panic or let them believe that someone who understood was present. She had been good at that job. She had been good at it because she understood soldiers in ways that civilians never could, because she spoke the language of controlled response and personal autonomy that military training demanded. "That's a good outfit," Elena said, positioning herself so he could see her without having to turn his head in a way that would disrupt the IV placement. "They trained you right. Your breathing is textbook stress response, and your vital signs show you understand what's happening. Means you're thinking clearly despite the pain. Which means you understand that your body is fighting against itself right now, and your training is getting in the way of your survival. You're in combat protocols when you need to be in recovery protocols. You need to let go of threat assessment mode. You need to let the doctors do their job. Can you do that for me?" James Walsh looked at her directly. She could see the calculation in his eyes, the assessment of whether she could be trusted, whether she understood what she was talking about, whether she had legitimate credibility. Then he nodded once, a small acknowledgement, and his muscles relaxed slightly. It was not a complete surrender of his military bearing, but it was enough. It was enough for the medical team to insert the 14-gauge angiocath into his left antecubital fossa, to begin running normal saline through rapid infusion pumps, to establish the arterial line that would allow them to monitor his blood pressure continuously. It was enough for them to do what they needed to do. But what Elena did not understand, what nobody in the room understood, was that James Walsh recognized something in her too. He recognized it in the way she moved. Economical, purposeful, without wasted motion. He recognized it in the way she understood what he was doing without needing explanation. He recognized it in the specific knowledge she had about ranger training and stress response, knowledge that you only had if you had been there, if you had trained with them, if you had operated in the same system. And as they worked to stabilize his injuries, as the medical team moved him from the trauma bay toward the operating room where the surgeons would attempt to repair what could be repaired and manage what could not, he was already understanding that she was the one. She was the one who could understand what happened to him. She was the one who could sit with him if things went wrong. She was the one he needed when the system became unbearable. The surgery took 5 hours. 5 hours of precision work, of finding and repairing vessels that had been damaged by fragmentation and blast pressure, of identifying sources of internal bleeding and stopping them through careful suturing and vessel ligation, of clearing debris from the body cavity, of re-expanding the pneumothorax with careful placement of a 28 French chest tube through the second intercostal space in the midclavicular line, of doing the 1,000 small actions that made up the difference between life and death. The surgical team placed monitors that would allow them to track his vital signs continuously. Arterial line for beat-to-beat blood pressure monitoring, central venous catheter for measuring central venous pressure, continuous pulse oximetry, electrocardiogram, end-tidal carbon dioxide monitoring. They worked under fluorescent lights in a sterile environment, with the kind of focus that comes from understanding that a single mistake could be fatal, that a missed bleeding vessel could mean exsanguination, that an infection could mean sepsis. The anesthesiologist maintained a perfect balance between keeping him unconscious and keeping him stable, managing his airway, administering blood products and crystalloid fluids, titrating medications to maintain his fragile hemodynamic stability. James Walsh came through it conscious on the other side. Barely, but conscious. His blood pressure was stable at 128/74. His oxygen saturation was holding at 98% now that his collapsed lung had been re-expanded and the chest tube was draining clear serous fluid. His heart rate was 92 beats per minute, regular and strong. His vital signs were holding steady despite the massive trauma his body had sustained. The surgeons had managed to stabilize him. The bleeding was controlled. The pneumothorax had been managed. The contaminated wound had been cleaned and debrided. He would live, at least for now. Whether he would ever regain full function, whether he would ever be able to return to the level of physical capability that his job demanded, remained to be seen. But he would not die on the operating table. The system had done what it was designed to do. He had been saved. They moved him to the intensive care unit. And here is where the protocol should have continued smoothly, where he should have rested and recovered and been monitored according to standard procedures, where the next phase of his healing should have followed naturally from the intervention that had saved his life. But something went wrong in the transition from crisis mode to recovery mode. Something shifted in how he understood what was happening to him. When Dr. Marcus Reynolds came to check on him the next morning, James refused to let him examine him. The refusal was not polite. It was not a request for time or space. It was a complete and absolute rejection of the doctor's presence, coupled with an attempt to remove his own IV lines, despite the fact that those lines were delivering critical fluids and antibiotics and pain management directly into his bloodstream. The nurses called for assistance. They tried to talk him down. They tried to explain that he needed the IVs, that he needed the monitoring, that he needed the medications that were keeping him stable. He responded to every explanation by becoming more agitated, more determined to free himself from the equipment. "I need to speak to the commanding officer," he said. his voice ragged from the intubation tube that had been removed only hours before. I need to report what happened to my unit. I need someone I trust. You're in a hospital, Doctor, Reynolds said, and his tone made it clear that he believed this should be explanation enough. You've been stabilized. You need rest and recovery. If you continue to agitate yourself, you're going to disrupt your healing process and compromise the surgical repairs we just made. I'm going to recommend that we sedate you for your own protection. The word sedate hung in the air like a threat. James understood what it meant. It meant loss of control. It meant being vulnerable. It meant putting his fate in the hands of people he did not trust, people he did not understand, people who were operating within a system that he could not predict or influence. It meant becoming someone who was no longer a soldier, but a patient, completely at the mercy of medical protocols and doctor's orders. It was the kind of thing that could break a person trained the way he was trained. He refused again, and when the nurses tried to replace the IV line that he had partially dislodged, he refused their touch. He refused the doctor's examination. He refused the medications that were meant to speed his healing. What he did not refuse was the presence of Elena, who had come in during the early part of his agitation, who had stood quietly in the corner, understanding the situation without needing explanation. You're scared, Elena said quietly, once the other staff had left the room in frustration. Which is normal. You've lost control. You're in an environment you don't understand, being treated by people you don't trust, and your training is telling you that vulnerability is fatal. I understand. I've been exactly where you are. But you're going to have to trust someone, and that someone needs to be me. Can you get my unit here? James asked. That's not how this works, Elena said. Your unit is deployed. Your command is probably 3 time zones away and doesn't even know you're injured yet. That takes time to process through classified channels. But what I can do is be here. And what I can do is understand, which is more than anyone else in this hospital can offer you. I've been a ranger. I've been to the places you've been. I speak your language. That evening, another physician arrived, Dr. Sarah Chen, the infectious disease specialist who needed to assess the risk of infection given the contaminated nature of the injuries. She approached the bed professionally, her clipboard in hand, her manner clinical and efficient. She did not understand that she was about to encounter the same absolute refusal. I need to examine the wound sites, Dr. Chen said, moving toward him with practiced authority. No, James said. His hand moved to the IV line. I understand you've been resistant to treatment, Doctor. Chen continued. But this is about preventing infection. You need... No, he said again. And this time his hand found the central line that had been placed in his subclavian vein, the larger bore that delivered multiple medications simultaneously. Elena, who had been standing near the door, moved quietly but quickly. Dr. Chen, can I speak with you in the hallway? Once outside the room, Elena explained what Dr. Chen could not have understood. He will not cooperate with unfamiliar staff. He's in combat protocols. If you try to force an examination, you'll compromise his compliance with all care. Let me document what I see. I have the training to assess for signs of infection. I can be your eyes. Dr. Chen, frustrated but pragmatic, agreed. She would accept Elena's assessments. She would provide instructions, but Elena would carry them out. Later, a third physician arrived, Dr. William Foster, the orthopedic surgeon who needed to assess the potential for surgical intervention on the traumatic fractures in his right leg. He too approached the room with standard protocols and standard expectations. I need to examine your leg, Dr. Foster said, beginning to pull back the blanket. The violence of James's response startled everyone in the room. He grabbed the blanket, pulled it back toward his body with surprising strength given his injuries, and his face transformed into something hard and fearless. "Don't touch me," he said. "Don't come near me." "Doctor?" Foster, offended by the refusal, moved toward the call button. "I'm calling for security. This patient is becoming a safety concern." Elena was already moving. "Doctor, please, come with me. Let me explain." In the hallway, Elena made her case again. "He's a ranger. He has been trained to resist. Physical examination without consent will be experienced as a threat. If you want to help him heal, you need to work with his psychology, not against it." "That's not standard care," Dr. Foster said. "No," Elena agreed. "But standard care is failing. And if you push, you'll lose him entirely. I can take measurements. I can photograph. I can relay information. But I need permission to do it his way." By that evening, word had spread through the medical staff. There was a patient in the ICU who would not cooperate with doctors. A memo was circulated. All examining physicians should check with the nursing staff before attempting direct patient contact. All clinical information should be gathered through the primary nurse, Elena Vasquez, who seemed to have some kind of understanding with the patient that nobody else possessed. The hospital administration became involved. Patricia Gaines, the hospital's chief administrator, called a meeting with the trauma team. She came to this meeting with a legal pad full of liability concerns and a list of hospital policies that were being violated by this patient's behavior. "We have liability concerns," she said, her tone clinical and administrative. "A patient refusing appropriate medical care, refusing examinations by qualified physicians. What happens if something is missed? What happens if an infection develops and we don't catch it early because we didn't have direct access to examine the wounds? We could face a negligence lawsuit. We need to sedate him, restrain him if necessary, to ensure we're meeting the standard of care and that we have proper documentation that we attempted all appropriate interventions." Elena, called into the meeting despite her lack of administrative rank, stood firm. She stood against 3 physicians, 2 administrators, and a lawyer who was reviewing the hospital's exposure. Sedation will trigger a crisis response in someone trained the way he's trained. His entire psychology is built on maintaining control. Removing that control through chemical means will create lasting trauma. It will create the exact opposite of healing. You're not going to cure him of his resistance through chemical restraint. You're only going to create a broken person. And yes, you'll have documentation that you tried standard care, but you'll also have created a permanent wound that will take longer to heal than his physical injuries. "You're making excuses for non-compliance," another administrator said, a woman named Jennifer who oversaw nursing protocols. "This patient is being difficult. We have policies. We have standards. We can't let one difficult patient dictate how we run our entire trauma unit." "I'm not asking you to change your protocols," Elena said quietly. But her voice carried absolute conviction. "I'm asking you to understand that different patients need different approaches. He's not a civilian who's panicking because of pain and fear of the unknown. He's a trained soldier whose entire psychology is built on maintaining control and autonomy in chaotic situations. Remove those things, and you remove his ability to heal. You can have all the medical interventions in the world, but if he's fighting against them, if he's in crisis mode, they won't work. I can provide the clinical information you need. I can document his status. I can prevent infection through careful monitoring. But I need to be the conduit, because he trusts me. And without that trust, you have nothing." Over the next 3 days, James Walsh presented an increasingly complicated problem for the hospital system. He was cooperative with Elena. He would allow her to check his vitals, to change his dressings, to administer the medications that she personally gave him. But with anyone else, he shut down completely. Dr. Reynolds was baffled and angry. The nursing staff was frustrated. The hospital administration was concerned about liability and creating documentation trails. The suggestion came to sedate him again, more forcefully this time. The suggestion was rejected by Elena, who told the head administrator in words that were professionally phrased but absolutely firm that sedating a Special Forces soldier without informed consent was a recipe for trauma that would prevent his healing rather than facilitate it. "He's fought through enemy interrogation," Elena said, speaking quietly but with absolute conviction in a closed-door meeting. "He's trained to resist stress. He's trained to maintain control of his mind even when his body is compromised. Sedation is not going to solve this. Trust is going to solve this. And I'm the only person in this hospital he trusts." "This is highly irregular," Patricia Gaines said. "This is a highly irregular patient," Elena responded. "He's trained for combat, not for civilian medicine. He's trained to survive in systems where the rules change by the second. He's trained to rely on people he knows over institutions he doesn't. If you want to help him heal, you work with that training, not against it." The hospital administration, not understanding the situation and not willing to spend resources on negotiating with a difficult patient, began the process of suggesting that he be transferred to a different facility. Perhaps the Veterans Administration Hospital could handle him better. Perhaps Walter Reed could take him sooner. Anything to avoid the legal complications and administrative challenges. It was during this discussion, during the early hours of the fourth morning, while James was alone in his room and fully awake and staring at the ceiling and understanding that he was about to be moved away from the one person who understood him. Understanding that he was about to be separated from Elena, that something shifted in his thinking. He looked at the whiteboard on the wall, the whiteboard that was meant for nurses to write his name and their names and relevant medical information, the whiteboard that had been filled in with clinical information and then periodically erased and refilled as shifts changed and new information became relevant, the whiteboard that documented his medical care, but that never captured who he actually was. The whiteboard that was completely, utterly under his control. He reached for the dry erase marker that sat in the tray below it. His hand was shaking from pain and weakness, from the effort of moving at all after major surgery. But his intention was clear. He was going to write something that would matter. He was going to write the thing that mattered more than any amount of medical intervention. He was going to write the name that was the only thing that would make this situation manageable. He took the marker in his trembling hand. He raised it to the whiteboard. Each letter was an act of will, each movement a negotiation with pain. He wrote slowly, deliberately, in letters that were large and uneven but absolutely clear. G-H-O-S-T, that was all. One word, one call sign. The name that had belonged to a ranger medic who had worked with his unit during deployments to hostile territory, who had understood how to keep soldiers alive, not just in their bodies, but in their minds, who had been trusted with the kind of absolute faith that soldiers only develop for people who have proven themselves in life or death situations. The name belonged to Elena Vasquez, though nobody in the hospital system would immediately understand that connection. But it was written now on the whiteboard in letters that were slightly uneven from pain and weakness, but absolutely clear in their intention. It was written as a plea. It was written as a prayer. It was written as the only thing a soldier could write when he needed someone to understand him. When Elena came in for her morning shift at 6 a.m, she saw the whiteboard immediately. She stopped 3 feet from the door. She saw her call sign written there, written in a way that could only be understood by someone who knew what it meant. She saw the effort in the uneven letters, the desperation in the size and placement. She stood very still, looking at that one word, and something inside her shifted. She looked at James. His eyes were open, watching her, waiting for the recognition, waiting to see if she would understand what he was saying without having to say it out loud. "I know," Elena said quietly. She closed the door behind her. She pulled the chair closer to his bed and sat down so that their eyes were level. She looked at him directly, and there was something in her face now that had not been there before. The look of someone who had put down the disguise of just being a nurse, who had allowed herself to be seen as what she actually was. "I'm Ghost," she said, "and I'm here now, and I'm not going anywhere. You can trust this hospital because you can trust me. You can trust my understanding of what you need because I've lived it. I've been in the places you've been. I've made the choices you've made. And I'm not going to let anyone sedate you. I'm not going to let anyone transfer you. I'm going to advocate for you until you're stable enough to be moved to Walter Reed with a medical team that understands what you are, who you are, where you've been. I'm going to be here. I'm going to make sure that you're not alone in this. Can you work with that?" James nodded. The relief that crossed his face was profound, as if a weight he had been carrying for 4 days had suddenly been set down. His shoulders, which had been held in constant tension, relaxed into the bed. His breathing, which had been shallow and controlled, deepened. He closed his eyes, and Elena could see the moment the fear left him. Not the pain, but the fear. The fear that he would be left to face this alone. Elena spoke to the head administrator that day. She spoke to Dr. Reynolds. She explained, in terms that were professional and clinical but absolute in their conviction, that she had assessed the patient's needs and had determined that his refusal to cooperate with the medical team was not a behavior problem, but a trust problem, and that the solution was not sedation, but the consistent presence of a staff member who had the professional and personal credibility to guide him through his recovery. She offered to adjust her schedule, to work additional shifts, to be available around the clock if necessary. She offered to be the primary nurse assigned to his case. She offered to take responsibility for his behavioral management and for ensuring that all necessary medical information was gathered and documented. Dr. Reynolds, who did not like being told what to do by a nurse, but who also understood that having a cooperative patient was better than having a resistant one, that having a patient who actually followed post-operative protocols was better than having one who was fighting against every intervention, agreed to modify his approach. The hospital administration, similarly motivated by the desire to avoid complications and negative press about how they handled military patients, approved the modified care plan. And Elena became, for the next 2 weeks, the primary point of contact between James Walsh and the medical system that was responsible for his healing. She sat with him during the difficult days of recovery, when pain management was a constant negotiation and infection prevention required vigilance and detailed wound assessment. She explained the medical procedures in language that someone with military training could understand. Not the technical jargon of civilian medicine, but the logic of physical response and physiological necessity. She advocated for his care in ways that protected both his dignity and his autonomy. She changed his dressings with a soldier's understanding of the difference between necessary exposure and unnecessary vulnerability. She monitored his vital signs, his blood pressure, his oxygen saturation, his heart rate, and understood what those numbers meant, not just clinically, but psychologically. She did the work that the medical system was designed to do, but she did it with the added element of understanding who he was. where he had come from, what he had experienced, and what he needed to feel safe enough to heal. The military notification system worked slowly, the way institutional systems always work. But by the third week, the calls had been made through proper channels. The commanders had been informed through secure communications. The appropriate military channels had been notified. A Special Operations Command liaison had been assigned to coordinate his care and ensure that his medical information was properly handled. And James Walsh understood that his unit knew what had happened, that people were aware of his situation, that he was not in this alone in an institutional sense, even if the person who truly understood him was the woman sitting beside his bed. Elena was the one sitting with him when the 3 soldiers arrived at the hospital. They came in civilian clothes because you could not exactly march through a civilian hospital in tactical gear without creating a situation. But you could see it in them anyway. The discipline, the focus, the specific kind of presence that comes from training in a unit environment. They moved down the hallway with the kind of controlled quiet that speaks of respect for the sacred space of a hospital. They moved like soldiers moving through enemy territory. Carefully, prepared, aware of every potential threat or obstacle. They stopped at room 412. Elena was sitting in the chair beside his bed, reviewing his charts, making detailed notes about his pain levels and his progress, documenting the medications and his response to them. She looked up when they came in. 3 soldiers, mid-30s. The kind of weathered expression that comes from years in the field, from being deployed, from spending time in places where survival was not guaranteed. Eyes that recognized what they were seeing immediately. A fellow ranger, someone who carried the marks of their unit, someone who had been trained the same way they had been trained. "I'm looking for the staff member who's been coordinating his care," the lead soldier said. He was taller than the others, with the particular bearing that comes with command. His voice was quiet but carried absolute authority. The kind of authority that comes from people following your orders when following those orders could mean death. "That's me," Elena said. She stood up, and her movement was confident but not aggressive. She had been trained by the same system they had been trained by. She understood protocol and respect and the particular choreography of military interaction, the understanding of rank and deference that comes from a system built on hierarchy and trust. "I'm Colonel David Holloway. James is one of my soldiers. I want to understand what happened to him. I want to understand why he was refusing treatment, and I want to understand why he specifically requested you." Elena looked at James. Her eyes asked the question silently. "Do you want me to explain this, or do you want to?" James nodded. He wanted her to speak, to tell his commander what had happened in a way that he could not yet tell it himself. "He's a ranger," Elena said simply. "Which means he processes situations differently than civilians do. He doesn't cooperate with systems he doesn't understand. And he didn't understand the hospital system, the medical protocols, the way decisions were being made about his care without his input or understanding. When he was moved to intensive care, he lost the sense of control that every soldier needs to feel to function. I was able to provide that. Because I'm also trained in that system. I understand how his mind works. I understand what makes him feel safe enough to cooperate with medical interventions. I understand because I've been exactly where he is." "And the request?" Colonel Holloway asked. "He wouldn't cooperate with anyone except you." "He wrote my call sign on a whiteboard," Elena said, gesturing to the board where "Ghost" was still visible, where it had remained untouched through shift changes and medical rounds. He needed to communicate that he trusted me. Because in his experience, trust is what matters in a crisis. Not rank, not credentials, not hospital protocols or medical authority. trust. And he knew he could trust me because I understand his background. I speak his language. I've been to the places he's been. I've made the choices he's made. Colonel Holloway looked at the call sign on the whiteboard. Something shifted in his expression. Understanding moved through his features like a wave. "You're a ranger," he said. It was not a question. "I was," Elena said. 75th Regiment, 8 years. Ranger qualified, combat medic trained. I'm a nurse now. But the training doesn't go away. The understanding doesn't disappear. You carry it with you forever. And in this case, I was able to use that training to help your soldier get the care he needed. I was able to translate between the civilian medical system and the military mind that he carries. The colonel looked at Elena for a long moment. He looked at the call sign on the whiteboard. He looked at his soldier lying in the hospital bed, at the change in his posture now that Elena was present, at the way James's entire physiological presentation had shifted toward stability and cooperation. Then Colonel Holloway extended his hand. "Thank you for taking care of him. Thank you for understanding what he needed. That's what soldiers do for each other. We make sure nobody is alone. We make sure the system doesn't override the person. You did that. You brought him back from a place where he was rejecting everything. And you brought him back through trust and understanding. That's what soldiers do." Elena shook his hand. The grip was strong, respectful. The grip of one trained soldier acknowledging another. The other 2 soldiers in the room stepped forward, and one of them rendered a salute, a gesture of profound respect typically reserved for commanding officers and for the fallen. Elena did not salute back. She did not have rank. But she nodded, and in that moment, something shifted in the hospital. The 3 soldiers who had come to check on their unit member suddenly understood what had been happening. They understood that the quiet nurse who had been listed on the charts as the primary caregiver was not just a nurse. She was one of them. She carried the same training, the same understanding, the same commitment to never leaving anyone behind. She had been willing to stand against the medical system, against hospital protocols, against administrative pressure, to ensure that one of theirs was not alone. Over the next days, as James continued his recovery, Colonel Holloway worked with the hospital system to ensure that he was transferred to Walter Reed with a proper medical team. With a team that understood military trauma and military psychology, Elena facilitated that transition, ensuring that all the information about his care was properly documented, that all the details about his trauma response were clearly recorded, that all the protocols that had been developed specifically for him were transferred with him. She did the work that allowed the system to work effectively, that allowed the military and the civilian medical system to coordinate seamlessly. But before he left, James asked to speak to Elena privately. She sat beside his hospital bed one final time, watching him as he gathered the strength to speak, as he moved through the pain to reach the words that mattered. He reached out and took her hand, the way a soldier takes the hand of someone he trusts with his life. "I don't know your real name," he said. "I only know your call sign. But I need you to know that you saved my life. Not just the medical part, the other part. The part where I was becoming someone else because I couldn't function in a system I didn't understand. You saved that. You reminded me that it's okay to be a soldier and to need help. It's okay to trust. It's okay to let someone else carry the weight for a while. It's okay to be vulnerable when you're with people who understand." Elena squeezed his hand. "Your unit never stopped carrying you," she said. "They were always there. I just helped you wait until you could feel them again. That's all I did. I held the space until your unit could get here. The discharge was processed. The paperwork was completed. The transfer was arranged with military efficiency and military respect. A medical team came and moved him from County Medical Center to the military medical system, where people who understood his background and his training would continue his recovery, where the culture understood soldiers and what soldiers needed. And Elena returned to her night shift, to the quiet work of nursing the people nobody else was sitting with, the people nobody else was advocating for, the people nobody else was staying for when the system moved on. But something had changed in County Medical Center. The hospital had seen something that it could not quite explain to its accreditation board or to its board of directors. It had seen a nurse who was more than a nurse. It had seen a system working at its best, not because of protocols or procedures, but because of trust and understanding and the absolute commitment to never letting someone be alone. The administration had questions. The medical staff had questions. How had they hired someone with advanced military training? How had they not known? How many other staff members were carrying hidden expertise that the hospital system was failing to utilize? Elena remained quiet about her background. She did her job. She did her shift. She continued to be invisible in the way she had always been invisible, present but not noticed, reliable but not celebrated. But the word had spread among the soldiers and their families. They knew. They understood. And when patients arrived at County Medical with military backgrounds, with trauma histories, with the particular needs that came from having been trained to survive in chaos and control, the hospital staff began to understand that they should call for Elena. They should ask for Ghost, because she understood what nobody else understood. She knew how to make it safe to be vulnerable. She knew how to create systems that allowed soldiers to heal without losing their identity. She knew that sometimes the most powerful medical intervention is simply being present, being understood, and being trusted with someone's fear. A month after James Walsh's discharge, a package arrived at the hospital's front desk addressed to Elena. It was a small box. Inside was a challenge coin, the kind of coin that military units give to each other as a token of respect and membership. On one side was the insignia of James's unit. On the other side was a simple inscription: "For those who understand, for those who stay." Inside the box was also a handwritten note, written in a careful hand that suggested the effort had cost him something. "Ghost, I don't know if I'll make it back to full operational capability. The doctors aren't promising anything. But what I know is that I'm going to try. Because someone showed me that trying matters. Someone showed me that being vulnerable is not the same as being weak. Someone showed me that it's okay to trust. That's going to carry me through whatever comes next. Stay safe, stay strong, and thank you for remembering that we are more than our diagnoses. Thank you for remembering that we are people." Elena kept the challenge coin. She added it to the small collection of artifacts that marked her transition from one life to another. She did not display it. She did not talk about it. She did not show it to the other nurses who wondered about her background. She simply carried it forward, the way she carried everything forward, invisibly, quietly, with absolute commitment to the work. She went back to her night shifts. She went back to the work of being present with the people who needed her. She went back to the role she had chosen for herself, the role of the person who stays, the person who understands, the person who makes sure that nobody has to leave this world alone. The hospital eventually documented the incident in a case study about patient cooperation and trauma response. They published a paper about the effectiveness of having medical staff members with personal experience in understanding the specific needs of military trauma patients. They made recommendations about hiring practices and training protocols. They presented the findings at medical conferences, where administrators and trauma surgeons listened and nodded and then returned to standard practices. All of it was professional. All of it was clinical. All of it missed the actual point of what had happened. The actual point was that One person had understood another person, and that understanding had transformed what could have been a tragedy into an opportunity for healing. The actual point was that sometimes the most powerful medical intervention is simply sitting with someone in their fear and saying, "You are not alone. I understand. I am going to stay." If you've ever been the person who understood when nobody else did, if you've ever been the one who stayed when everyone else moved on, subscribe to see more stories like this. Stories about the people nobody notices until suddenly everything changes because of them. Elena did not read the case study. She did not need to. She already understood what it had taught the hospital. She carried it forward in every shift she worked, in every patient she sat with. In every moment she chose not to move to the next task, but to remain present with someone who was struggling. She understood that sometimes the healing is not in the cure, but in the witness. Sometimes the medicine is not in the IV, but in the presence. Sometimes the recovery is not in the procedures, but in the remembrance that you are not alone. This is the work that nobody sees. This is the healing that nobody measures. This is the medical care that never appears on anyone's official record, but that changes everything. This is what happened in room 412 of County Medical Center, when a soldier refused everything except trust, and a nurse who understood soldiers showed him that trust could be given, and that sometimes the most powerful thing a person can do is stay.